And now I will request Dr. Hasan Shahriar Kallol, Assistant Professor of Surgical Oncology, National Institute of Cancer Research and Hospital, Dhaka. He will present on short-term outcomes of oncoplastic breast surgery at a tertiary care center in Bangladesh.
Thank you very much. So today I'm going to present about the outcomes of oncoplastic breast surgery in Bangladesh. Before going to the main presentation, I'll give some introduction regarding the oncoplastic breast surgery. We know that for a century together, mastectomy was proven as effective therapy for breast cancer. In early 90s, the paradigm has been shifted and breast conservation therapy took the place. And with the similar disease-free, distant disease-free, and overall 5 years survival. So, for this oncoplastic surgery, the issues to be considered is oncological outcome, cosmetic outcome, and quality of life. For oncological outcome, we see the margin clearance, that is whether there is a need for re-excision, ipsilateral breast recurrence, and overall survival. So, there are many studies which have already proven that there is no difference between the overall and distant disease-free survival or local recurrence between the breast conservation surgery, oncoplastic breast surgery with mastectomy. Even after neoadjuvant chemotherapy, meta-analysis has proven that there is no actually difference between the outcome of locally advanced breast cancer after neoadjuvant chemotherapy. We can do safely oncoplastic breast surgery. So now the issue is cosmetic outcome and quality of life. So we don't want this kind of results after BCS. Then oncoplastic breast surgery comes in the scenario, which is a combination of oncological clearance and plastic surgical technique, which achieves wider excision margins without compromising the cosmetic outcomes. So we do it for stage 1 and 2 breast cancer usually, and would response to neoadjuvant chemotherapy. Even for LABC, we can do oncoplastic breast surgery. And there are a few techniques like volume displacement and replacement, and level 1, level 2, sometimes level 3. So decisions are taken with respect to maximum excision volume ratio, the requirement of skin excision for reshaping, and all these things. So we actually follow quadrant by quadrant approach of oncoplastic techniques, and here are a few results of our work. V-mammoplasty for lower inner quadrant tumors, and J-mammoplasty. Hemi battering technique for 12 o'clock tumors, battering technique. We sometimes do wide-guided wide local excision with precentric mammoplasty. This is the result. Some round rock mammoplasty. Even we do precentric mammoplasty for upper quadrant tumors. This is the 12 months after surgery and chemoradiation. Even we can do oncoplastic breast surgery for unplanned lumpectomies, which actually had post-operative wound infection. So there was a vertical incision, unfortunately, but we converted this into a transverse incision, and this is the final outcome after chemoradiation. So if the tumor is not palpable, we can put markers, and then we can do wire-guided excision. There is a case of a patient with triple-negative breast cancer, 557 tumor left breast, and after putting hydromass inside the tumor center, and after neoadjuvant chemo, there was no tumor actually, there was a complete radiological response, and here's the marker only. And after the surgery, this is the appearance 3 months after the surgery. So, if we compare oncoplastic breast conservation surgery with breast conservation surgery alone, the meta-analysis showed that OPS gave actually better outcome than BCS alone. So in better cosmesis, re-excision rate was comparable, and results were close for both the local and distal recurrence rates. So now the Bangladesh perspective where our study took place. We know that in US, the 70% of cases dealt by the surgeons are oncoplastic breast surgery, but in Bangladesh, the scenario is a bit different. So with the increase of awareness, demand of breast conservation is more than before. And to standardize the OPS, necessity for widespread training is required. That's why we have conducted this study. It's a prospective observation study done in March 2021 to 2022 June in the Department of Surgical Oncology at NICRH, our National Institute for Cancer Research. And the study population, 48 patients who underwent OPS or oncoplastic surgery. These are the eligibility criteria, and now the results. So in our series, most of the patients were below 40 years. This is very unfortunate, but this is the scenario. And most of the patients are from low socioeconomic status because ours is a government hospital, and most are premenopausal. Very few had comorbidities. Regarding the site of tumor, most are upper outer quadrant. Clinical T stage was T2 and N1. Unfortunately, most of the tumors were HER2 positive and triple negative. Medial clinical size, tumor size was 29 millimeter. Most of the patients received neoadjuvant chemotherapy because most of our patient bulk was HER2 positive or triple negative. That's why most of them actually had neoadjuvant chemotherapy. And after neoadjuvant chemotherapy, most of the patients were T0 or T1. So there was considerable downsizing after chemotherapy. So we have done total 48 cases, and there are so many types of surgery we did. Most of them are round-wall myoplasty, some are just volume displacement. There are some LICAP, some keyhole myoplasty, and other transposition flaps. We did mostly axillary clearance, but some SLNB and axillary clearance after SLNB. Pathological T stage mostly was T2. So, post-operative complications. So we have only 15% cases had some sort of complications, which is very comparable to other studies in the West and other parts of the world. And cosmetic evaluation by 4-point Likert scale. Most of the patients, the median cosmetic score was 30, and most of the patients had a good to excellent cosmesis. If we consider the quality of life score in 100, most of the patients were highly satisfied with their body image with a score of 91 to 100. And 22 patients were in 70 to 80 score range of fear of recurrence, but 25 patients were below 70 score with higher fear of recurrence. If we consider the satisfaction with treatment, most of the patients were very satisfied with their treatment. And regarding cosmetic result, they said that the treated breast resembles the opposite breast very much. It is patient's treatment. So if we consider the association between cosmesis and comorbidity, there was no significant association. BMI and post-operative complication, no association. But pre-operative T stage and cosmesis, there is significant association. That means the higher the T stage, there is less cosmesis. And if the patient gets NSCT, post-operative complications were more, and it is statistically significant. Association between post-operative complications and cosmesis, there was significant association. And the post-operative complication body image, there was significant association. But there was no association between post-operative complications with fear of recurrence. So in conclusion, we can say that OPS can be performed to different age group of patients, irrespective of receptor status, use of NSCT, BMI or comorbidity, with oncological safety in respect to margin clearance, acceptable post-operative pain and complication, and excellent cosmetic outcome in short term. It has a positive impact on all aspects of quality of life with a high patient satisfaction in respect to body image, fear of recurrence, treatment satisfaction, and cosmetic result. So there is significant association between post-operative complication and body image. Pre-operative tumor size and post-operative complications are significantly associated with cosmetic outcome after OPS. It can be done by trained specialists with a favorable outcome even in a low resource setting in carefully selected patients. So we have presented this paper in a few conferences in the UK and in the Asia Pacific Breast Cancer Summit in Bali. And it has been, the abstract has been published in European Journal of Surgical Oncology, and we are actually following these patients And our subsequent presenter, our associate professor of our department will present that because we are following this patient up to 3 years now. Thank you very much.